Good morning. How's everybody doing? So I want to thank the hosts here in Boston for inviting me and hosting me here. I'd also like to start by lodging two complaints. The first is the brochure clearly had a very nice fall sunny day in it before agreeing to come. And this morning when I mentioned that, somebody said, well, yesterday was gorgeous. I said, I got it at 11 p.m. They said, well, tomorrow's going to be great. And I said, I leave at 6 a.m. So the world is conspiring against me. Second complaint I'd like to lodge is I was guaranteed that if the Red Sox were in the World Series, that the home games would be during this weekend. And that didn't happen. For any Sox fans, I will note I was born and raised in Houston. So see me later and we'll talk outside. I am rooting for them because nobody likes to see a Dodger win. So for anyone who's nursing their depression this morning from last night, the support group meeting is going to meet after lunch down the hall. So I think Dr. Benson did a great job of outlining a pretty complicated condition, transverse myelitis, and my job here is to complicate things further. So for those of you who said, oh, I'm going to go to a symposium, it'll be fun, I'll meet some people, and now at 9 o'clock in the morning you're being hit with pictures of spinal cords and molecular biology, all I can say is buckle up, it gets worse from here. But the goal here is to give a pretty diverse community in the room a sense of the diversity of biology that leads to all the trials and tribulations that you or your loved ones deal with on a daily basis. And for everybody to recognize that for anyone in the room who's been affected by whether it's transverse myelitis, acute flaccid myelitis, neuromyelitis optica, acute disseminated encephalomyelitis, optic neuritis, all these conditions that are a mouthful to say, from the science side of the world and from the personal side of the world, there is something we all have to learn from each other. So even if you're walking around with a name tag, a title, a diagnosis that isn't the same as somebody else, there's a lot of commonality here. And one of the things that's been incredible about the Transverse Myelitis Association, which is very much unlike other advocacy groups, is it has been a big tent group, an umbrella group, where the idea was to create a home for individuals with a diversity of biologies and pathologies, because there was a recognition that when you open the doors, we actually get better at treating all of them. And I'll try and make that point as we talk about acute flaccid myelitis today. So the title here, The Emergence of Acute Flaccid Myelitis, is incorrect. This is really the reemergence of acute flaccid myelitis. This is something that's been around for a long time. And if you're willing and comfortable, how many people here themselves or have a loved one who has carried the diagnosis of acute flaccid myelitis, just so I get a sense, okay? And now keep your hands up. How many here have heard of acute flaccid myelitis in the news or anything else? Okay, so great. This is something that's garnering a lot of attention, and for the families of individuals who have been stricken with this condition, it is a scary and devastating experience to go through. And for those of you who have not had a personal interaction with it, listening to the news, it raises concern. And so I'm going to try and put all of this into context today. Dr. Benson gave you a roadmap of the nervous system, and I'm going to reinforce just a couple things because it actually sets into motion a lot of the conversations we're going to have. And there's a diagram of the spinal cord and then a cross-section of spinal cord. And Dr. Benson showed you a cartoon of it with what's called gray matter in the middle and white matter on the outside. And I want to focus on that because it makes a difference. Understanding this anatomy is critical to understanding all of your or your loved one's symptoms. And why is there variability amongst a group of individuals who all had spinal cord damage? Because acute flaccid myelitis is within the realm of transverse myelitis, meaning if you have inflammation or the damage to the spinal cord, whether it's the immune system or infection or a combination of both, that's myelitis, that's damage. What differentiates acute flaccid myelitis is which part of the cord is preferentially damaged, and it gets back to Dr. Benson's geography. So just to give you a sense, why does this matter? So depending on which part of the spinal cord, and I'm going to focus on the motor side of things. I'm going to leave sensation out for a moment. We're just talking about movement. Depending on which part of the spinal cord is damaged, you get different symptoms. So if I damage the white matter, which is off to the side, in that white matter is the connection from your brain going down, so a single wire, a single neuron that starts in the brain, sends its axon all the way down the spinal cord. So if we're talking about the leg, that one cell is 3 feet long. It's got a cell body in the brain, and then it sends its projection all the way down to the spinal cord, where it's going to connect with a second cell, and that second cell lives in the gray matter. And that second cell then sends a wire out to the muscle. So I tend to talk about it as wire number 1 or wire number 2. Those are the 2 wires of movement. So if you affect the white matter, then you're affecting wire number 1. If you affect the gray matter, which is there in the front, you're affecting wire number 2. The symptoms that a person has when wire number 1 is damaged is different than the symptoms a person has when wire number 2 is damaged. And so let's explain that difference. So when wire number 1 is damaged versus wire number 2, in wire number 1, the white matter, that's where you get tight muscles, spasms, spasticity. And while there is weakness, meaning an inability to volitionally move the muscle, it is combined with a tightness. When you damage wire number 2, you can't move the muscle, but it's loose and flaccid. So there are some individuals in the room who themselves or have family members who have had weakness from inflammation in the spinal cord with really tight muscles. That's almost always a wire number 1 issue. For those of you who have muscles that are loose and the muscles are atrophying, that's almost always a wire number 2 issue. And then there are those of you and those patients that we treat that can actually have both, where in one area it was wire number 2 damaged, but as you can see on the picture, if this was in the neck, and there's inflammation in the spinal cord, I might damage wire number 2 going to the arms, but be damaging wire number 1 on its way to the legs. So the arms may appear loose, but the legs appear tight. And everyone sits around saying, well, how can this be? It has to do with what Dr. Benson stressed, and that's the geography. If it happens in the neck, you can have a mixed picture of which wire gets affected. So within acute flaccid myelitis, what are the challenges relative to diagnosis? Well, the first is acute flaccid myelitis affects wire number 2. Remember, in the spinal cord, we get the first few millimeters of wire number 2 of what is a 3-foot long neuron if it's going to your big toe. And so you had that one 3-foot neuron going from your brain down your spinal cord. It connected with a second neuron that's 3 feet long going to your big toe. And if I affect the first few millimeters of wire number 2, clinically, I can't tell the difference between that or damage to that nerve in the last 3 millimeters. All I know is wire number 2 is damaged. And at the bedside, I have no idea if the damage occurred within the spinal cord or after the exit of the nerve from the spinal cord. All I know is it ain't working, and that's not very helpful. We have to narrow it down. And so this is where we do a lot of testing. So for a lot of patients with acute flaccid myelitis, they originally get diagnosed with Guillain-Barré syndrome. And in fact, that's a common misdiagnosis of transverse myelitis. Guillain-Barré syndrome is a disease of wire number 2 outside the spinal cord. And so it kind of makes sense why the misdiagnosis occurs, because I can't tell the difference at the bedside between the first 3 millimeters or the next 3 feet. And Guillain-Barré is the next 3 feet. Acute flaccid myelitis is the first 3 millimeters. So when we have somebody presenting with acute weakness, we do tests, not just because we can bill for them, but we do bill for them. But it's also because we need to figure out, I am not good enough at the bedside to figure out the difference between those 2 locations. So MRIs and electrical testing can help us sort out what's going on. So let's say you do all the testing and you get convinced it's that gray matter of the spinal cord. It's not the next 3 feet of the peripheral nerve, but you're really in that gray matter. Now you have to say, well, what caused the damage? And this has been the source of a lot of controversy and a lot of angst within the public sphere and the public health sphere. There are lots of conditions that can damage wire number 2. There are lots of conditions that can damage wire number 2 in those first 3 millimeters. I'm listing some here as just different examples. There are certain genetic conditions that can lead to a slow death and progression over years of wire number 2. There are certain toxic exposures that can kill off wire number 2. There are infections, and we're going to spend a lot of time today talking about that. And then there are immune-mediated conditions that can kill off wire number 2. And so when you hear in the news there are lots of potential causes for somebody presenting with wire number 2 damage, yeah, absolutely. Do we think that's what's going on in the outbreaks that we're going to discuss? No, we think we know what's causing it. But in general, it can be a lot of things. This syndrome of acute flaccid myelitis is not new, which is why the title is not the emergence of acute flaccid myelitis, it's the reemergence. So here's a letter between 2 physicians explaining a child who had a respiratory illness, got better, and then days or weeks later couldn't move and was paralyzed. And this is a letter that went between 2 physicians in 1808 in Sweden. And it's a very classic description of what turns out to be poliomyelitis. And this is something that's been with us for a long time. And when I say a long time, I mean a really long time. So if you go back into Egypt and you look at hieroglyphics on this one tablet, and there are other examples from the 15th century BC, you see an individual with a shriveled leg, one leg that looks normal, walking with a staff, and then a severely atrophic leg. This is the classic sequelae of poliomyelitis. Now, there's not hieroglyphics there saying this person had a respiratory infection and a week later got sick or anything like that. This is our interpretation of that tablet. So it's a little bit of conjecture. He could have fallen off a pyramid, I suppose, but we interpret it as poliomyelitis. As you get into the recorded medical literature going back to the 1700s, very classic, very clear descriptions of poliomyelitis. And so even in what was a seminal treatise on pediatric conditions, there's a section, and this is from the 1700s, dedicated to what is classic poliomyelitis, with a GI illness followed by lower extremity paralysis. This is not a new condition. And so we knew there was this syndrome. We knew that predominantly children could become ill and then have wire number 2 die off. And in fact, if you go to the 1700s, 1800s, there are autopsy studies, and they look at the spinal cord and they see wire number 2 is dying in the spinal cord. So they were able to correlate the symptoms that these kids were having with where the damage that was done. But just like today, everybody was arguing about what's the cause. Everyone was arguing, what is this? And quickly, as we get into the later 1800s, the focus is on infections, and with the birth of virology instead of bacteriology. So bacteria are big organisms from a biology point of view. Viruses are really tiny. And as you get to the late 1800s, work is progressing quite nicely on separating out viruses from bacteria. And it was in 1908 that the first proof came of a transmissible virus that could cause the paralysis. And this was the isolation of what became called the poliovirus. Here is a very important historical fact. The term poliomyelitis had existed for decades. And when they found this virus, they called it the poliovirus. But there are lots of causes of poliomyelitis. This just happened to be overwhelmingly the most prevalent and the one that was identified. It explained the overwhelming majority of cases. And it is worth noting one other thing. They tried to pass from the spinal fluid, from the blood of an infected human, a young boy who had died from polio, to different animals. They couldn't recreate it. Finally, they had to take actual spinal cord tissue and inject it into a certain strain of monkey to recreate the paralysis. And through a series of steps, they proved it would have to be a virus and not a bacteria. But the point of that is, it's actually very difficult to get the virus from a body fluid and pass it on to the next person. It's not easy to replicate in the lab or easy to isolate the virus. Pathologically, the other thing that's worth noting within poliomyelitis, and for those of you who don't spend days looking at tissues of spinal cord, I'm sure that's just one of you. This looks like a very nice modern art picture of dots. And what I'll say is where that letter A is and the arrow, and you see that kind of big trapezoid grayish structure, that's a neuron. And as you get down to the B picture, it's not so gray and it's not so rectangular and all these little blue dots around it. That's a dying neuron, and the blue dots are cells from the immune system coming in and responding to something in the tissue. The poliovirus, and if you look at the history of the poliovirus, the infection elicits an immune response in the spinal cord. So Dr. Benson explained that in the classic description of transverse myelitis, the immune system gets confused and is in the spinal cord for the wrong reason. In the poliomyelitis world, the immune system is going for a good reason, but sometimes the immune system overreacts and causes accessory damage beyond what the virus causes. And we've seen this in polio over the years. And if you look at the history of polio from a public health perspective, early on and even throughout the world, there were small outbreaks of cases through the 1800s. 4, 5, 10, 50 cases spread out. But then, as we all know from history, something changed. And as you get into the early 1900s and really the 1920s, the 30s, the 40s, polio becomes an epidemic condition with tens of thousands of children being paralyzed every year from this transmissible condition. And the question is, what happened? Why did we go from a virus that had very small impact on us as human beings, very rare impact, to a big deal from a public health perspective? And it's an interesting story. The best data suggests that it has to do with us actually getting more sanitary, not less sanitary, as a society. And here's how the theory goes. So before the epidemics, polio is spread usually by contaminated water. And what would happen is infants would have several months, 6 months, of a little bit of antibody to the poliovirus that they got from their mother. And if you expose an infant with a little bit of antibody to the poliovirus, to the actual virus, that antibody protects them so they don't get sick, but the exposure is enough for them now to mount their own immune response to the virus. It's basically vaccinating them. They were given the exposure in the safety of their mother's immunity. So if you start cleaning things up, and you clean up the water supply, and you start washing your hands, your infants don't get that little exposure in childhood anymore at a period of time when they would have been protected. So we raised generations of children who hadn't had the exposure. And we created a population that hadn't created natural immunity to the virus. So all of a sudden, we had hundreds of thousands of children who, when they saw the polio virus for the very first time, couldn't fight it off. And that virus would cause significant damage to their spinal cord. Does that make sense? It's kind of a weird twist. And when you look at the history of poliomyelitis in the United States through the 1930s, 40s, 50s, it preferentially affected individuals in the highest socioeconomic status. Individuals who had indoor plumbing and who had made changes in lifestyle because their children were not getting inoculated early on in life. So what happened to eradicate polio? And on this slide, it's worth noting that when you see that big drop, that's at the introduction of mass vaccination campaigns within the United States to give back children the immunity that they weren't getting naturally from the environment. And so what happened in terms of polio eradication? So since 1979, there have been 0 endogenous cases, human-to-human transmission cases of polio in the United States. There were vaccine-associated cases because there were 2 vaccines. One was a live virus given orally to replicate the natural exposure. The other was an inactivated virus given through injection. We saw very few cases of oral poliovirus-associated polio. The risk was about 1 in 2 million of that occurring. And as of 2000, the United States stopped using the oral polio vaccine at all, and we haven't even seen a vaccine-associated case within the United States. And so if you broaden it to the Western Hemisphere and you look just to the Americas, North and South America, there has not been a native case of polio in the Western Hemisphere since 1994. There are only 3 countries left in the world with any endemic polio, and the World Health Organization is working hard to eradicate it, just like we did smallpox. What's interesting is the infrastructure that was set up to do this was based on surveillance. And this is going to become critical for what we're seeing today in public health. So there were these huge infrastructures set up for what was called acute flaccid paralysis surveillance, which meant if a child showed up at a hospital who had weakness and they hadn't just fallen off their bike, and that weakness was flaccid paralysis, you had to report it to public health authorities, and those children were tested for polio. Because the World Health Organization said we need to know where polio is in order to figure out where to put the resources. As of today, the overwhelming majority of countries continue to have a flaccid paralysis monitoring program, even though there are only 3 countries that still have endemic polio. There's still over 120 countries monitoring. The United States and some countries in Europe are the only countries that have stopped the surveillance program. Everybody else in the world, even in countries that have eradicated polio, have kept the surveillance going. And the data from them is fascinating. So if you look to the Americas, which hasn't had a natural case of polio since 1994, and in fact, if you look at the 1980s, it was pretty much gone. There were random cases. If you look at the data from these countries, where you see NPEV at the end, off to the right, the last two things, that stands for non-polio enteroviruses. So the same family of virus as polio, but not the polio virus. So a genetically related. And those non-polio enteroviruses were being identified in, frankly, the majority of children who were presenting with acute flaccid paralysis and were proven not to have polio. The same surveillance program goes on in India, which hasn't seen a native case of polio in years. And what I want to draw your attention to is the bottom paragraph. A total of 59,000 plus acute flaccid paralysis cases were investigated in India in 2012, 53,000 in 2013. I'm not sure we call this a rare disease if we have hundreds of thousands of children worldwide developing flaccid paralysis, and we're still trying to sort out the cause. It is I'm going to argue in a moment, a very rare complication of viral infection. We have billions of people getting infected with viruses and a fraction becoming paralyzed, but this isn't as rare as we might think. So what about the United States? So what was our recognition in the post-polio era of this syndrome? So this goes back to 2014, which is where we got most of the awareness. There was a cluster of acute paralysis in children identified in Colorado. Originally 8 children, the number grew, and the reality is this had been recognized prior to 2014, but not in the same cluster or the same amount. And in 2014, the public health world said, why did we have these children all of a sudden show up with paralysis that was unexplained? There was a group of us in North America who had been talking about this for a while, and when this outbreak hit in September of 2014, we all jumped on a phone call. And I'm going to tell this story just to give you a sense of your community is bigger than you think, and the people invested in these things are bigger than you think. We sent out an email on a Monday or Tuesday evening saying we are arranging a phone call for Thursday at 11 p.m. Eastern time to discuss these outbreak of cases and to try and coordinate efforts. And by Thursday at 11 p.m. Eastern time, there were over 30 scientists and clinicians from 30 different centers on the call, sharing data, going through what they were seeing, talking about case definitions. There are a lot of folks who are invested in getting this work. It is worth noting, if you look at the US literature up until this point, and you look at the CDC reports, there were at least 4 different terms being used to describe the syndrome. It was on this call that the proposal was made, can we all just call it the same thing so we can all share data? And we agreed on the term acute flaccid myelitis. You may hear the term acute flaccid paralysis, polio-like syndrome, all these different words. The group of clinicians and scientists agreed, let's just call it acute flaccid myelitis so we can at least all be talking about the same syndrome at the same time. And that's where the term that we're using now got agreed upon. And if you look at these outbreaks, what happened in 2014, so the blue lines, and this is reproduced from the CDC website, shows their surveillance starting, and I shouldn't call it surveillance, their reporting of cases that are reported to them and confirmed by them started in August of 2014 and then continues. This is a voluntary report and this has garnered a lot of criticism, and we'll talk about the reporting. It's worth noting that they're now updating their numbers every Monday, and last Monday they said 66 confirmed cases, 22 states. This Monday they'll confirm 72 in 24 states, and they're still working up about 80 cases nationwide to see if we can confirm them. There have been over 150, 160 reported cases that are still being confirmed. And what's interesting about this is the every other year phenomenon. So 2014, 2016, 2018, and the question is why? Why would it happen every other year? And that has to do with causation. So let's look back at 2014 to 2016 and look at some of the epidemiologic data to figure out the cause. So in 2014, when we had these children presenting with paralysis without a clear etiology, It happened just after there had been the largest outbreak of a certain viral infection called enterovirus D68. This is a cousin of polio. It's in the same family of polio, but it had not been described in a significant way as causing paralysis in the past. And yet we had this nationwide outbreak of enterovirus D68, and if you were a child with asthma who got enterovirus D68 respiratory infection, there was a high likelihood you were going to wind up in the ICU. There were really severe respiratory infections happening. And then there was a segment of children who, after the enterovirus D68 infection, were representing later with paralysis. And so there was a question of, Jesus, this virus causing this paralysis. We haven't seen this virus like this in the United States ever. And now all of a sudden we're seeing paralysis like we've never seen. It sounds suspicious. And then we get to 2015 and there aren't that many cases. And we're like, well, maybe it wasn't that enterovirus. But guess what? The enterovirus went away. We weren't seeing it in respiratory isolates during this period of time in any significant form. And then you get to 2016 and we start seeing it in respiratory isolates again, and we start seeing paralysis again. So from an epidemiologic perspective, as this virus comes and goes within the United States in terms of prevalence, we see the coming and going of flaccid paralysis in a significant form. Now, it's worth noting, there are cases of flaccid paralysis year-round. And so I'm not saying there's an association between enterovirus D68 and all flaccid paralysis. What I'm suggesting here is there's an association between the virus and these outbreaks, these clusters that happen in late summer, early fall, every other year. And so if you do the calculation from 2014 and you look at the number of children who were infected with the virus, it was only a very small few where the virus went further to cause paralysis, to leave the lungs, go to the spinal cord, and kill wire number 2. Which is essentially what we think is going on. So when we looked back in Dallas at our own experience, so in 2014 we had 3 inpatients, we didn't have any in 2015, we had 7 in 2016. In 2018 we've confirmed 8 cases, number 9 got transferred to us last night from Lubbock. When we looked back retrospectively in our transverse myelitis center to say, well, how many of the kids would have met the definition of wire number 2 dying preferentially, these were our numbers. This was not new, but we were lumping a lot of cases together under the title transverse myelitis and not recognizing we had a subtype, a variant that was affecting the gray matter in a significant way. And I blame my mentors for this. They taught me wrong. Is Doug in the room? Michael, have you seen Doug Kerr yet? Jack, you haven't seen him? Okay. So when he's here, you can blame him for all of this, because what he told me when I was being raised, neurologically speaking, was he said, Ben, transverse myelitis is a white matter demyelinating disease. Let me translate that sentence. Ben, transverse myelitis is a wire number 1 problem. And he showed me this beautiful slide where there was little blue cells invading the white matter and killing off, and we called it a demyelinating disease. And he convinced me, and he showed me these beautiful MRIs. And so off to the right, that center gray area with the 3 white spots, that center gray is the spinal cord, and those white spots shouldn't be there. And he said, look, there's scar tissue in wire number 1. This is a wire number 1 disease. And I just believed him. And I went along with it. So when I was seeing kids, I would say this is atypical transverse myelitis. It went a little worse. And I kept going until we got to 2011, 2012, and we were talking with colleagues in California. We said, this doesn't seem right. We're seeing, for being so atypical, we're seeing a fair amount of kids who have gray matter involvement. And I won't bore you with the MRIs, but we categorize retrospectively the different MRI patterns of whether or not we affected the central cord, the gray matter, just the gray matter. And again, we don't have to go in detail into those, but we counted up prior to 2014 all of our transverse myelitis cases, and we asked the simple question, how many children actually had gray matter involvement versus what Doug told me, which is this is a white matter disease. It was more than half the kids had gray matter involvement. It was depending on whether you did take it as gray matter restricted or mixed, both wire number 1 and wire number 2, the majority of children would have evidence of damage to both the gray and the white matter, well over 50%. And so this has raised a lot of questions about whether or not acute flaccid myelitis today is similar to the poliovirus-induced paralysis. Should we be worried? And there's a couple things to note in terms of the similarities or differences. So the first is the poliovirus for every 100 to 1,000, somewhere in that range, people that get infected by the polio virus, somebody's getting paralyzed. It is a very neurovirulent virus. It loves to go to the spinal cord, and it loves to kill wire number 2. The enteroviruses, and if we believe that it is the cause, infects a lot of people, but is a much smaller number where it goes to the spinal cord and causes damage. They both can cause a fast progression of symptoms. There are multiple phenotypes seen. If you read the historical literature of the poliovirus and poliomyelitis, there were some kids with sensory symptoms. There were some kids with wire number 1 being damaged at the same time as wire number 2. Poliovirus wasn't just a wire number 2 disease, and what we're seeing in acute flaccid myelitis is the same. There's a spectrum. Some of the kids have only wire number 2 damaged and nothing else. And then some of our kids have a mix of wire number 1 and wire number 2 being damaged. And that gets very important for treatment. Even if your family hasn't been intimately involved with AFM, for those of you who have been watching in the news, I think you can get a sense that there's some controversy circulating over this condition. And the Transverse Myelitis Association has tried to be an educator and be a place for people to come together and information. And I'm going to start this sentence by saying I am not on Facebook. I don't have a Facebook account. How many people here are on Facebook? Yeah, I'm like the odd one out. Okay, so you're all going to have to tell me what everybody's having for dinner and what their kids are wearing, because I'm not seeing it myself. But on Facebook, there's also a lot of concern and controversy over what actions are our leaders taking or not taking relative to this condition. I'm going to transition now to my criticisms of how this is being handled, and I think there need to be some changes. I will preface this by saying our public health officials are actually very dedicated individuals trying to serve the community and are significantly under-resourced for the job we ask them to do. And so from the outset, I don't think there is any maliciousness involved or a conspiracy theory or anything like that. I think we're looking at the data differently, and I'm going to tell you the way I'm looking at the data. So if you go to the CDC website about acute flaccid myelitis, and I love the title, What We Know, and I'm like, I wish this page was longer. And one of the things they say is there are lots of things that can cause AFM. And for those families and frankly clinicians who've been in the trenches with this for years and affected, this is a little bit of a slap in the face because the data suggesting an association between enterovirus D68 and this condition is overwhelmingly strong. And while this statement is factually true, I had it as an opening slide at the beginning. There are lots of ways to kill off wire number 2. Do we really think we're having outbreaks of 20 different causes between August and November every other year? I find that hard to believe, scientifically speaking. And they justify the lack of commitment to causation with a sentence, and it's not highlighted here, lower down, where they say they can't find the virus in the spinal fluid. And since they can't find the virus in the spinal fluid of all the cases of AFM, they are not willing to indicate that that is the cause. So I've encouraged everybody to then go to the CDC website on polio, where they say, so this is the AFM, where they say we can't find it in the fluid. And then if you go to their site on polio and you read right there, you can't get the polio virus out of the spinal fluid. And yet the CDC has no problem saying the polio virus can cause poliomyelitis, even though it's pretty much impossible to isolate the virus out of the spinal fluid. Remember, in order to transmit it, we had to grind up a spinal cord and inject it into the next person. And it has to do with these RNA viruses. They are very difficult to isolate from spinal fluid. And so one of my frustrations is if we're waiting for that as some sort of new standard to prove causation, then we should take down the association between poliovirus and poliomyelitis because we're fitting the exact same pattern as they are. The other concern I have was relative to treatment guidelines, and this has caused a lot of controversy. So early on, and I mean really early on, with the best interests in mind, the CDC put out a treatment recommendation with zero data around AFM or transverse myelitis, where they actively discouraged the use of steroids or plasma exchange in children who were affected by this condition, and they had waffling language on IVIG. It may help, it may harm, we don't know. And their concern, which is a very valid concern. so I do not discount their concern at all, was if you have a viral infection of the spinal cord and an immune system is trying to suppress that virus, do I really want to give somebody anti-inflammatories? Would I lead to the virus causing more damage? And I have to stress that is a absolutely valid concern. The way that concern was handled is where I have my criticism, because this sent a chilling effect through the field. Because if you have a public health organization saying, hey, Dr. Greenberg, don't do that, and I'm in a room with a family talking about treatment options, it's very hard to justify. I mean, we are a bunch of cowboys in Dallas, but this is getting pretty serious in terms of going maverick. It's your child's health, and we're trying to decide what to use. We had been using steroids and plasma exchange in the setting of transverse myelitis for years, even before we recognized that variant. Remember how Doug messed me up, and so we were going one direction? So we went back and we looked through our historical data in terms of what happened to children who had gray matter involvement, who we gave steroids and plasma exchange to before the CDC said, hey, Ben, don't do that. And it turned out the majority of kids were getting better. And what was going on and what we think is happening now, and I have to stress this more than anything else, this is my theory, this is not medical fact, what I'm about to say. I'm not making a standard of care statement. This is where the data is leading our team, is that for the kids who have both wire number 1 and wire number 2 damage, the immunotherapies, the steroids and the plasma exchange, are helping to salvage wire number 1. So when we have children who come in with a neck lesion, to Dr. Benson's geography, and both their arms are flaccid and weak, you are all now experts, and you would say that's wire number 2 in the spinal cord, right? But if they come in and their legs are weak and really tight, that's wire number 1. And from a real estate perspective, it makes sense. If the immune system was going in to fight the virus in the center of the cord, it might cause some damage to wire number 1 on the way in. And when we give steroids and plasma exchange to kids in the acute setting, we're seeing a nice response for the legs. We're getting kids who are quadriplegic back to walking. I am not sure and do not have any data to suggest that we are salvaging the damage to wire number 2. We do not know that at this point. But it's really nice to walk. And so we're trying to sort out when and where should we be using different therapies. So the implications of all this are to recognize that not all transverse myelitis is autoimmune. Dr. Benson very eloquently talked about an immune system getting confused and going in. All transverse myelitis is inflammatory. But whether the immune system is there for the right reason or a confused reason separates out autoimmunity versus inflammation for other causes. And just like the polio syndrome can affect a large part of the cord and have a secondary immune response, so can the acute flaccid myelitis we're seeing today. So what do you need to do after acute flaccid myelitis? And I know I need to wrap up. So here's a list of what we're seeing. And I have to stress, we are seeing recovery. It is slow. It is painfully slow. It is slower than anybody wants. But we are seeing a direct correlation between the patients and families who are doing the most rigorous routines of physical therapy, which is really hard to do with 4, 5, 6, 7, 8, 9, 10-year-olds. You know, at some point, they really just want to be on their iPad and not be doing therapy. But for those who can keep it going, we are continuing to see improvement. And I know we're going to have a whole talk about rehabilitation. From a public health perspective, if I get on my soapbox, this is my soapbox. I would ask that our officials publicly state there is a high likelihood of an association between an enterovirus or family of enteroviruses with these outbreaks, because the moment they say that, we can start to focus our research attention to, should we be thinking about vaccinations in the future before what we have today follows the history of polio over time? Do we need to be developing a vaccine, even if we shelve it, just to have it ready to go if needed? The second is, I'm a believer there needs to be mandatory reporting. The United States does not have mandatory reporting of acute flaccid paralysis. This is easier said than done. It's not easy to do mandatory reporting, but I actually think it's, from a public health perspective, needed. We need centralized testing. These viruses are hard to identify. We need to come up with a standard reference lab to prove causation. And I would highly recommend that our officials who are doing the epidemiology and the public health refrain from premature recommendations around treatment. I would love to see the investment in the studies to figure out which are the treatment approaches, but to make proclamations with literally zero data is always concerning. This is an area that we're dedicated to. So the Conquer logo in the bottom left is the name of our clinical program down in Texas. While I'm the one representing the group today, I have to stress I have a large, diverse set of colleagues who are very dedicated and devoted to trying to improve the lives of individuals with AFM, transverse myelitis, ADEM, NMO, et cetera. And it really does take a group effort. And as Dr. Benson started her talk indicating that her kids, or at least one of her children, asked the why, the what's, the this. When I started in this world, these were my two, and they've gotten older. They're actually older than this now. Notice no Red Sox garb is being shown in this picture, but they're rooting for the Sox. About 4 years ago, on a Saturday, we had a new admission, and I said to my younger daughter, the one holding the baseball, I said, I have to go in the hospital for a minute. She says, what does the child have? Because she knows all the names. I say, well, I think it's transverse myelitis. And she said, haven't you fixed that yet? I was like, oh, I mean, come on. Like, you guys ask all the time, but now I'm getting it from her. And so she's keeping up with this, and hopefully she'll do a better job than Doug or I did in terms of sorting through all this. So again, I appreciate the sponsors here, the sponsors that made this happen. The Transverse Myelitis Association, our hosts in Boston. And I'll just end by saying, besides being a clinician, a scientist, I'm a member of the board of the Transverse Myelitis Association, and in 2019 will be the 25th year of the Transverse Myelitis Association, started in 1994 by a small band of very dedicated families. And Sandy Siegel's here off the side. Everyone should thank him and give him a big hug as they see him. The theme for the 25th year, I wanted it to be called Write Us a Damn Check. And I was told that was not a very eloquent, I just said, just say what you want. We need to fund a lot of different things, so write us a damn check. They said that won't work. So the theme for the 25th year is about caring, and the TMA cares. And there is a board, and we really do. There's a board out there with Post-it notes, and what we're asking for everybody to do at the meeting is to write down what you care about relative to your personal diagnosis, your family member, your loved one's diagnosis. What do you care about? What do you want to see? We're going to put it all on the board, and as a community sort out what are our priorities and what are we looking to do. It was great to see so many hands raised for first attendees at a symposium, and hopefully for all of you it's a worthwhile day and experience, and looking forward to hearing all the other speakers. Thank you all.